Fantastic. All right, everybody. I think we'll make a start. I'm sure there'll be a few extra people that join us. Good afternoon, and thank you for joining us for today's webinar on weight loss drugs, the need for nutrition and lifestyle support. I'm Dr. Lauren Struschak, and I'm a senior scientist in the British Nutrition Foundation's Nutrition Intelligence team. As you can see from the agenda, I have the pleasure of chairing today's session, which has a really fantastic lineup of speakers. I hope you're looking forward to learning from their knowledge and experiences in what I think we can all agree is a really fast-moving area of health. To begin with, I've got a few bits of housekeeping. So firstly, just to make you all aware that this webinar is being recorded so that we can share it with you after today's session. Following all our speakers that are going to present, we should have time for a short Q&A session where we'll try to get through as many of your questions as possible. If you do have questions, feel free to pop them in the Q&A chat function on Microsoft Teams at any point during the presentations. And if you can state who the question is directed to, it will help us direct the questions at the end. You should also be able to upvote your favourite questions so that we can prioritise the most popular questions at the end accordingly. Firstly, just a few slides from me to set the scene. So the majority of obesity medications include a GLP-1 receptor agonist. So they mimic the effect of endogenous or naturally produced GLP-1 hormones. GLP-1 is produced by the gut in response to food intake, and there are a range of GLP-1 receptors throughout the body, and therefore GLP-1 receptor agonists have a range of physiological effects. The ones we know about at the moment that are linked to weight loss include increased insulin production and decreased production of glucagon, both of which improve blood sugar control, which explains why they've been used traditionally in type 2 diabetic patients. In the stomach, GLP-1 slows gastric emptying and gastric mobility, helping us feel fuller after eating. And GLP-1 also has direct effects on the areas of the brain that regulate satiety. All of these things help contribute to reductions in appetite, therefore reduced calorie intake, and therefore the substantial weight loss that we've been seeing. Regarding the pharmaceutical licensing, the UK MHRA has licensed GLP-1 RAs for anyone with a BMI over 27 with one obesity-related condition, and this puts a staggering 26 million people eligible for these drugs in the UK alone. However, NICE, who sets the guidelines for use by NHS England, have approved GLP-1 RAs for use in people with a BMI over 35, plus one weight-related comorbidity, or for people who have a BMI between 30 and 34.9, if they meet the criteria for referral to specialist weight management services, still putting about 3.4 million people in the UK as eligible. This is quite a big task, and therefore NHS England have adopted a 12-year rollout programme with 220,000 people targeted in the first 3 years based on clinical need, which is currently restricted to people with a BMI over 40. This means approximately 97,000 people are receiving obesity medications in the first year of this rollout through the NHS. But it's estimated that around 1.5 million individuals in the UK are paying out of pocket privately for obesity medications, but appreciate that that number is quite difficult to track. And with this increased usage, there are a number of concerns, or as I like to refer to them, unintentional consequences facing users of obesity medication. We've got high discontinuation rates, with up to 20 to 50% of people discontinuing treatment within the first year, which possibly could be driven by gastrointestinal symptoms, such as nausea, vomiting, diarrhea, constipation as a side effect of these medications. We've also got weight regain following the discontinuation of the medications, with up to 2/3 of weight loss being regained within the first year. And finally, there's a range of potential nutrition-related unintended consequences, some of which our speakers are going to go into more detail today. And with that, it's my pleasure to hand over to our first speaker, Dr. Dwayne Mellor from the University Hospital of Leicester NHS Trust in the UK and the University of Canberra in Australia. Dwayne is an experienced clinical dietitian and researcher, having worked both in the NHS and within academia. He works to support public understanding of science and nutrition alongside editing academic journals and texts and helping develop nutrition policies. Dwayne will be presenting on GLP weight loss drugs, their impact on appetite and implications for diet-related health. Dwayne, I will now stop sharing and can hand over to you if you want to share.
Can you see my slides okay?
Yeah, we can see those. Thank you.
Perfect. So thank you for the invitation to talk about this. I was adding in sort of my clinical thoughts as well of working with a number of patient groups, mainly in the diabetes field. And is it going forward? Yeah. So I just put a statement of interest in that. A long time ago, I was thinking when I was doing my PhD, I was involved in some of the very early long-acting GLP-1s in type 2 diabetes studies. My PhD was partly funded by the food industry. I have in the past worked with pharmaceutical companies, but I've not worked with any GLP-1 or weight management, weight loss companies in the last 10 years at least. So we've had a little bit of this. We've got in the UK currently 3 licensed GLP-1 which are used in weight loss. There's also sort of exenatide, which has gone away a little bit now, which is semaglutide, which is also known as Wegovy or Ozempic, liraglutide, which isn't used that much now in terms of weight loss, and tirzepatide, which is Mounjaro, which is a dual agonist, which acts on not just GLP-1, it acts on GIP, which has 2 names. It's a insulgenic peptide. We may soon have a triple agonist in retatrutide, which also has an effect on glucagon. So we've got a growing area, and as we go forward, these drugs are becoming more and more potent in their effects on weight. As is already said, they started off as diabetes drugs, working on a mechanism where we know that orally consumed foods, carbohydrates, have a greater insulin response than if they're given IV. And this led to the development of these drugs, and knowing that glucagon can be high in patients with type 2 diabetes, and maybe sort of in people with insulin resistance linked to having higher body weight. Rapidly growing in weight management, and I've used slightly different data, which is from a 12,000 household survey, which suggests that 44.1% in this year had a household reporting taking these products. So they're becoming very, very widespread across much of society, as well as the NHS. Already touched on the mechanisms. We need to look at how these affect nutritionally. I think from a patient point of view, the benefit some people say is the reduction in food noise from the environment, then less driven to eat food. That may also have effects on other addictive behaviors. The gastric emptying can be linked to the nausea, and some of the advice we give around nutrition might be linked to that as well. The satiety and the central effects on appetite are well known. And then we've got the effect on sort of insulin mediation and suppression of glucagon, which are important, and particularly for my area of interest, working in diabetes. We've already touched on NICE guidance. I won't go into it anymore, but it must be alongside diet, physical activity, and behavior change to get a wraparound care. There may be slightly different BMI thresholds for individuals from different ethnic backgrounds and heritages. And we also need to note that within the UK setting, Scotland has quite different criteria. Having said that, and it's been touched on by Lauren, the rollout is staged over a number of years, and different ICBs or commissioning groups may have slightly different criteria based on capacity. And capacity is possibly something we need to think about. Do we have the capacity to roll this out in the NHS? What will be the interaction? And we've got someone from a pharmacy background talking next, the interaction with different health professionals, and what will be the interaction of online delivery services, and how do you keep those safe? These are all interesting debates that hopefully will come across this afternoon. So my thoughts so far, I think the big one for me is actually working with people who are taking these drugs. It goes from before you had these as options, it could feel from both sides, and having these conversations frankly now, quite adversarial. You were asking them to look at weight management. They were struggling. You thought you were criticizing them as a person. They were not succeeding. They were coming back, if they came back, having not been successful. And it was very negative. So it gives an opportunity for a positive consultation, that you have tools that can help move them forward. Then you can put in the other bits of behavior change to support them, health improvement. But that could also come at a cost. That does diet now needed anymore? Is physical activity needed anymore? Is behavior change needed more anymore? Or is it needed even more? Is it needed less or more? Difficult one. And I think the big thing, again, is this sort of opposing argument. It shifts the focus of treating obesity as a disease. It's not an individual's fault. which is important. There are many factors, there are lifestyle behaviors which contribute, but it makes it be treated as a condition. But also, does that then shift the need for having lifestyle interventions away? So it's a complicated picture. On the whole, I think it's a positive tool, but we need to use it wisely. So where do lifestyle interventions fit in? We need to highlight them at the initiation of the treatment, but we may not need to start them then. So we need to build them in, but do we allow someone to have success first? Because these are quite often individuals who've struggled, and I mentioned this adversarial relationship with health professionals. We may need to add in sort of pharmaceutical effects. We know that it delays gastric emptying. Is nausea the side effect that helps weight loss, or do we use that to help train eating behaviors? So we're looking at slowing down eating habits so you don't get as much nausea. So you're working to line your behaviors with the effect of the drug. So that gives you better success long term. We don't have the data. This is all hypothetical. And what happens afterwards? How to support weight maintenance? We've never been good at supporting weight maintenance, so we need to think about that. So the side effects: nausea, constipation is quite often reported as well. Then nutritional deficiencies. I think, although we don't have a lot of evidence, they're most likely to be the effect of a reduced food intake from an already nutritionally limited diet. So maybe a diet that's low in micronutrients, protein, is decreased even more. And clinically, we see much bigger reduction in energy intake, possibly going into 1 meal a day, right from 3 meals a day, compared to some of the studies. Again, that's due to study design. There may be some additional effects of the drugs on metabolism, but that might be slightly small. We also need to bear in mind loss of lean mass, loss of bone mass, which happens with weight loss. Is it exaggerated with these drugs? So we have study produced this year. Again, have to read this study carefully because it suggests that there's a higher risk of malnutrition in patients who see a dietitian. It's probably those who refer to a dietitian with higher risk. Aside from that, it shows that the prevalence of deficiency is quite high. It was mainly around sort of anemia, which is common in the adult population, and sort of it does increase sort of the risk as well as sort of mitigating the loss of muscle mass. So if we look at what we've got as a population before we start these drugs, we've got a suboptimal diet at a population level. And we can look at the National Diet and Nutrition Survey that highlights that. So if we limit that, we can have problems. And so the focus needs to be placed on nutrient density and adequate protein. I'm not sure we need to go high protein, but we need to focus on that adequate diet and assessing and supporting that. In terms of constipation, some centres may advocate the use of laxatives, which I've heard of. Increasing fibre, if you've got a reduced food intake, that can be a challenge, but because you could push out other key nutrients. Maintaining fluid and helping physical activity. The physical activity will help with other effects. The nausea, I've already touched on that. Is it a desirable side effect, which in the early days of these drugs, it was quite often said by some clinicians that was the case. But I'd argue we should use this to help develop a more mindful, better eating behavior, looking at posture eating, those sort of habits around the eating experience. If we look at the physiological one, there is data to suggest that gastric pH is dropped by about 20% with some of these GLP-1s. And we need that for iron and B12 absorption. And there is a study showing that there's a reduction in intestinal iron absorption seen with GLP-1 RA. So do we monitor patients for ferritin and blood counts? Should that be part of routine care? We wouldn't want to fortify without actually knowing if there's an actual true risk of deficiency. It may have an effect on B12, but that could be exaggerated by concomitant use of metformin because we know that lowers B12 levels. And there's one paper that's even suggested it could be a false deficiency because the way people of higher body weights, bodies handle B12. So we need to be careful in considering these being blanket. In terms of body composition, do we risk sarcopenia or increased risk of sarcopenia and frailty in adults who are taking these as they age? We don't know yet. The role of diet quality I've already mentioned, and protein, but also physical activity seems logical. Load-bearing exercise. We're starting to see some admissions with poor appetite, and you stop the drugs. These are drugs that are weekly drugs that have a long half-life. How long do we need to wait before we can actually support the appetite? And then if we're looking at enteral feeding, so some of these patients are high risk of things like stroke, they may have dysphagia. How do we tube feed them? We don't know. The guidelines currently are to stop GLP-1s if someone's had a stroke before tube feeding, but have effect on the gastric emptying, so residual volume and things like that, which slightly gone out of favour, but we might need to think slightly differently as this population ages. So we've got a changing population. So in terms of practical strategies, I think protein and adequate nutrient density, quite a simple one. Looking at the relationship with food and building a positive relationship with food going forward. Hydration and fibre is tolerated, and looking at that food environment, because we're looking to try and help people maintain food behaviours afterwards, and consider supplementation where necessary, where indicated by biochemistry. We've got a position statement which I was involved in from the British Dietetic Association and British Nutrition Foundation, and you need multidisciplinary care. They shouldn't be seen as standalone solutions. They are not solving our problem with our food environment. They must be holistic and have wraparound care. And this care should involve a multidisciplinary team. I apologise, I missed the word pharmacist up there. I think pharmacists should be in that list. And I just noticed now, and I apologise, but we need dietitians, pharmacists, psychologists, physicians, and exercise professionals. So we're handling this patient care in a very holistic, multidimensional way. Dietitians specifically, because that's what I am and I've been asked to talk about, we need to screen and monitor ongoing to support dietary adequacy. We need to help manage side effects related to nutrition, help preserve the lean mass, support the behaviour change, and look at those cues around food and consider what's happening at the end. So we need to be planning forward with individuals because they may not wish to stay on this drug for a long term. And currently within England, there's a 2-year window on them before in terms of their license. A big concern is how we access them. A lot of these prescriptions are private because the way it's been rolled out in the NHS, does that affect supply? Are they given to people with the highest need? Are we actually looking to be preventative with these drugs? Or are we waiting to have multiple complications before we start using these drugs? So are we using them in the best way? So, yeah, and there are a lot of very good private providers, but if people are not being open with sharing body mass index, their mental health issues, their dietary factor through an online system, how do we manage that? So do we have equal access? Is there sort of capacity in our healthcare system to support this number of people? And yes, we need to roll these out because they're important drugs which do help improve health significantly in individuals living with higher body weight, but we still need to address the impact of our food environment on our public health. We need to look at both ends of this. And just as a summary, I think these are a key new tool to support people living with obesity. I have no doubts about that. We need to be aware of the positional and nutritional risks, although evidence is still emerging, and we're largely based on consensus and theory. I can't emphasize enough this idea of multidisciplinary working. So we have wraparound care, so people are supported as they go onto these agents, as their journey on these agents progresses, and as they sort of discontinue these agents to maintain that weight loss and those health benefits. So thank you very much, and I'll hand over now.
Brilliant. Thank you so much, Dwayne. There was some really, really key insights there. Particularly enjoyed the information you were providing around kind of the practical strategies for that wraparound care and how that might be different for different groups and the best timing for implementing these. Just a reminder to everyone, we will have the Q&A session at the very end, so do use that Q&A function. And while we're getting the slides for the next presenter loaded up, I will just introduce our next speaker, who is Sahar Shahid. Sahar is an independent prescribing pharmacist and board member for the National Pharmacy Association. She is a UK-based prescribing pharmacist, entrepreneur and board director for Scotland at the National Pharmacy Association, and is the founder of both 24-Hour Pharmacy, which is an innovative online pharmacy specialising in weight management, women's health and holistic care, and the Pharmacy Consultant, a governance and compliance consultancy for pharmacy owners. Sahar has been recognised for her leadership and innovation. She has supported thousands of patients across the UK, trained prescribers nationally, and is passionate about raising standards in digital healthcare while creating accessible, patient-centred services. It's a pleasure to introduce Sahar today, who will be presenting on the role of pharmacists in diet and lifestyle support for GLP-1 users. Fantastic. So I think your slides are there, Sahar. So whenever you're ready.
Good afternoon. Hopefully you can all hear me okay. Thank you so much, Dwayne. That was a great start to this webinar. So my name is Seher Shahid, and what I'm going to talk to you for the next 10-15 minutes is really about the role that pharmacists can play for diet and lifestyle support for patients that are on GLP-1s. So what we do know, like Dwayne had mentioned, GLP-1s are transforming weight management. Drugs like semaglutide, tirzepatide, they have clinical significant results for weight loss. They're having positive impacts not just on weight loss, but many other health conditions such as diabetes and cardiovascular risk. But what we do know is that drugs alone are not the full solution. For patients to have long-term success, it absolutely depends on diet, lifestyle, mindset, and behaviour change as well. And pharmacists can play a key role in supporting patients through that. Next slide. My lovely assistant Bridget is going to be changing my slides. So why pharmacists matter? So our position as pharmacists is quite unique when it comes to the healthcare system. We are the one provider that is accessible without an appointment, and we see many patients on a regular basis, sometimes even daily. So we're definitely a profession that's trusted by the public. We're also experts when it comes to medication safety for monitoring adherence, side effects, and red flags. And we really do have insight to patients' daily lives. Like I said, patients are coming to us on a regular basis, every week, every month, and even daily. And we build that relationship, that trust, where patients can then confide in us for not just their healthcare, but just life in general. The amount of patients that have shared some really personal things, the good and the bad, when I've worked as a pharmacist in community pharmacies, is just so heartwarming. And we really do have the skills to bridge the medical prescribing with the lifestyle guidance. So this is absolutely why we're in a really good place to support patients when it comes to GLPs and wraparound services. Next slide. So what we're seeing right now in practice is there is some challenges with patients that are using GLP-1s, the mindset of a quick fix. This is something that I absolutely reiterate to all my patients when they start treatment, when they even come to ask me about treatment, that the GLP-1s are an amazing tool, but it is just one tool among many other. And that's the key thing. It absolutely needs to be done alongside the diet, the lifestyle interventions, and the mindset. And especially if you want long-term success in keeping the weight off. So it's about helping patients get out of this mindset of just a quick fix. But equally, like Jane had mentioned at the very beginning, it's also about recognising obesity as a chronic condition. And it's not, using a GLP-1 is not an easy way or a cheat. So it's really helping patients feel comfortable as well around their choice of treatment. One of the things that we are seeing a lot with patients is the management of gastrointestinal side effects, the nausea, constipation, diarrhea, vomiting, the abdominal cramps, sulfur burps, and we play a pivotal role in supporting patients when it comes to managing these side effects through some of the tips that can be that's around how they eat, smaller portions, avoiding fatty, rich processed foods, cutting down on fizzy drinks and alcohol, and staying hydrated. But equally, where appropriate, there are over-the-counter remedies as well. We also find that a lot of patients will skip meals. One, obviously, because their appetite is suppressed, which then leads to poor nutrition. They're not eating enough and they're not getting the nutrients that they need. There's also a huge amount of anxiety that I see from a lot of patients about weight regain after stopping. And what we know with the licensing of GLP-1s, that it's for weight loss and for weight maintenance. And again, it's really about understanding, even as a healthcare professional, that obesity is a chronic condition, and it's not about someone reaching their target weight and then we all of a sudden stop treatment because they're within a healthy BMI. It's about how do we actually support that patient to also then maintain, and what does that look like, and it's very individualized for every patient. And one of the things that we've put a really prime example this week is about a lot of misinformation that's getting put out there with perhaps people that aren't medically trained, and really trying to cut through that noise and give patients the right information. And again, pharmacists are really in a good position where patients can pop in, ask a question, and get the right information so that they can also make informed decisions. So, you know, we're supporting patients in many ways, whether it's just supporting them with the right information, giving them tips around how to manage their side effects, or improve their diet and lifestyle as well. Next slide. So why is lifestyle support essential? Because like I said, the GLP-1s are just one tool, but what happens beyond the injection? If we only just use the injection and don't focus on lifestyle and diet, we are allowing patients to be at risk of being nutrient deficient and having other issues when it comes from not having enough calories or nutrients as well, because the suppression is too much. We absolutely need to support patients with a healthy lifestyle that allows them to preserve their muscle mass, so increasing protein in their diet and highlighting the importance of resistance training as well. A lot of patients don't realise how sleep and stress management can absolutely affect their weight outcomes as well. So sometimes I'll have conversations with patients that are eating very clean, they're exercising really well, they're in a calorie deficit, they're doing all the right things on paper. But then when I ask them, like, are you going through any stress? Or, you know, how is your sleep? And that's when they realize that actually they're probably not sleeping enough. They're maybe burning the candle on both ends. Work has perhaps been particularly stressful. They're maybe going through things personally, and they don't actually connect the dots and understand that actually sleep and stress can absolutely have an impact or stall their weight loss journey as well. So again, we're able to give a lot of practical advice on how to manage better sleep hygiene and lower stress levels as well. And if we don't support patients with lifestyle support, the weight regain risk will absolutely be there. And, you know, most patients, like 1.5 million in the UK, are currently getting this privately. They're spending money and getting these treatments privately. And you don't want them to then have all the results reversed if they don't continue with the lifestyle change. And absolutely, there's a huge element of mental well-being and, you know, relationships with food that absolutely needs monitoring. So like we've mentioned already, there absolutely needs to be a multidisciplinary team that support patients through this as well. So bringing in, you know, psychologists or coaches and mental well-being, you know, webinars and all sorts of resources that are available that you can support if you are somebody that's providing this, bringing that in, bringing other experts in to support the patient as a whole is absolutely fundamental for ongoing success. Next slide. So as a pharmacist, it's all about adding value to every interaction that I have with patients. I'm very fortunate that I will speak to my patients on a very regular basis, minimum at least once a month before their new prescription is given. And that allows me to have that touch point with patients. Now, on average, some patients, you know, not even if we just take patients out of it, as human beings, we need to be exposed to something at least 5, 6, 7 times before the penny drops, right? So it's not just you say it all in your first consultation and that's it, the patient's going to go away and they're going to absolutely implement every piece of advice that you give them. If only it was that easy. The whole point is that we absolutely need to reinforce the same things and the key messages over and over again throughout this whole journey. So we're absolutely there to reinforce the nutritional and dietitian advice at every touch point. Not only do patients get to see me every month, but they also have access to me throughout the month because, you know, they might experience side effects, and I always encourage them to get in touch with me throughout the month whenever they need it, and that's really important. Patients need to understand that that's what we're here for, to support them. We can provide simple, practical dietary advice. Things like, you know, if someone is suffering with constipation as one of the side effects, you know, can we increase their fiber, increase their hydration? If they're suffering from nausea, you know, advise them of small meals, and encourage physical activity. And sometimes one of the key things that I do with my patients is, I actually say to them, you do not need to be 5 days, 6 days in the gym, like, going crazy. It's really about doing the small things that you can do easily, but then it becomes a habit and it's consistent. Now, for example, like, sometimes, in my work, at a desk doing consultations. I've got a walk pad, so I do a lot of the things like while I'm on my walk pads, because sometimes when I'm giving this advice to patients, you also absolutely have to take your own advice as well. So it's about it's about encouraging patients to understand it's not about striving for perfection. It's just strive to be consistent and do what you can manage, but do it consistently. And once that becomes a habit, you can build on that. And absolutely, like I said, monthly reviews, that's that opportunity to check in. And equally, even if things are going great, you absolutely need to have that check-in, because then that's where I can encourage you and give you that well done and motivation to keep going. But equally, if things haven't been so good, it's that opportunity for me to say, that's okay, let's draw a line under it. And if things haven't, the results aren't going the way that you want this month, this week, let's draw a line, and I just want you to focus on two key things. It may just be your steps and your hydration, and break it down, rather than patients becoming really overwhelmed and trying to exercise, eat clean, sleep for 8 hours a day, not have any stress, and be very, zen and relaxed. Like, that's not real life. So these opportunities with the pharmacist absolutely support patients as well. And also, we are, able to signpost to other colleagues when we're with a patient in a consultation, and actually we're realizing they need more support around their diet because they really aren't grasping the basics. We can absolutely refer them to the appropriate other healthcare professional as well. Next slide. So I just wanted to share some examples of patients, of conversations where a simple interaction with their pharmacist had led to better outcomes. So a patient was feeling very exhausted, and they had, low calories and poor protein intake. A conversation with me meant that then I was able to advise them of increasing their calories, because again, patients didn't, the patient wasn't eating enough. That was resulting in them feeling very fatigued. And then I supported them in ways of how they can actually get protein into their diet quite easily, whether it's a protein shake, helping them understand like snacks or things that are, dense in protein that they can take, but also equally healthy. And helping them even simple things like understanding how to track their calories and their macros using MyFitnessPal. A lot of patients, will come to me and say, no, I'm absolutely in a calorie deficit. I'm absolutely eating enough protein. But until they actually track it properly, they realize that perhaps they weren't eating enough protein or eating too little or too much. And what that resulted in is the patient then obviously started to feel much better. Their well-being was much better, and their progress was starting to move in the right direction. Things like persistent nausea. Now, we absolutely know that nausea is one of the common side effects, but as a pharmacist, I'm able to advise practical tips on how patients can resolve their nausea. Firstly, it's really about expectation. It's about helping patients understand they will experience these side effects at some point, especially at the beginning of treatment and with every dose escalation. So simple tips like smaller meals more often and hydration, or peppermint teas can have been known to help with patients. And then what that meant was the patient's adherence to treatment was definitely improved, and they weren't reluctant to then continue, or the risk of stopping treatment as well, because now we managed to support them with their nausea. Another one, fear of weight regain. This is definitely something that I'm now seeing a lot as we are going into maintenance phases with patients now being on this treatment for over a year. So again, it really is about reinforcing the long-term lifestyle habits. Now, I will very much talk to patients around their diet and lifestyle from the very beginning, and it's almost about planting those seeds from the very beginning, and drip feeding patients every single month, so that when they get to the point where their weight has now, they've reached their target weight, now they're thinking about maintenance, or perhaps thinking about what happens after the GLP-1s. I want patients to be in a place where their mindset is strong, their daily habits are exactly that. It's a habit that now has changed into, a more positive lifestyle. And then patients are, doing all the things that they need to absolutely be doing. So I always advise my patients that during treatment from the very beginning, start to build these habits so that when you stop the treatment, it doesn't feel like you have so much work still to do. You started to get familiar with how you should be eating, how you should be moving your body, and how you should be in a more positive mindset. So all of these patients are then supported, in this way. Next slide. And I think collaboration is key. If we want success for our patients, it's really about looking at that whole multidisciplinary team. As pharmacists, we're not just there to dispense and supply the medicines. We're there to educate, we're there to motivate and support patients throughout their treatment. And it's really about bringing lifestyle and medication together for sustainable change, and working with dietitians, doctors, PTs, the whole kind of healthcare infrastructure to really support patients as and when they need. Slide. So just some key takeaways. I genuinely believe GLP-1 changes the physiology, but lifestyle changes support the trajectory of people's health. And that's the key thing. And pharmacists have a critical role in bridging medicines and lifestyle for sustainable weight health long term. And if anyone on here is a pharmacist, happy World Pharmacist Day today as well. Thank you.
Thank you very much, Sahar, and happy World Pharmacist Day to you as well. It was great hearing your on-the-ground personal experiences, and those case studies were really nicely laid out to show really great examples, so thank you for those. Just a reminder to everyone to keep popping your questions in the chat and to upvote your favourite questions so that we can prioritise them accordingly at the end. It's a pleasure to announce the final speaker in this webinar, who is Dr. Dariush Mozaffarian, who is the Director of Food is Medicine Institute at Tufts University in the US. Dariush is a cardiologist, public health scientist, and distinguished professor and Jean Mayer Professor at the Friedman School of Nutrition, Science and Policy. He's also a professor of medicine at Tufts School of Medicine and attending physician in the Division of Cardiology at Tufts Medical Center. His overall goal is to create the science and translation for a food system that is nutritious, equitable, and sustainable. He is a globally renowned expert in food is medicine and has authored more than 600 scientific publications on nutritional priorities for cardiometabolic health and on evidence-based policy approaches and innovations to advance nutrition security, reduce diet-related diseases, improve health equity, and reduce healthcare costs in the US and globally. He has served in numerous advisory roles, including on the President's Council on Sports, Fitness and Nutrition, and his work has been featured in an array of media outlets. Today, Dariush will be presenting on the nutritional priorities to support GLP-1 therapy for obesity, pragmatic approaches to supporting healthier lifestyles.
Thank you so much.
Slides are being shared. Lovely.
Yeah, thank you so much. Hopefully you can hear me okay. It's a pleasure to be here, and it's so nice to build on all of the prior presentations, which really laid the foundation for what I'm going to discuss. So I first want to highlight that while these drugs are effective, many of the effect sizes that are seen in the randomized trials, as with many drugs, are not replicated in real world practice. And so here's a study from the United States, about 1,000 patients who had been treated with semaglutide and stayed on the drug for over a year. And in contrast to the higher weight loss seen in the trials, the weight loss among non-diabetic patients for obesity treatment was about 11%, so smaller than what's seen. And so we're talking about a 10% weight loss even for people that stay on the drug in real world practice. As everyone has highlighted, these drugs are effective. They're really an important agent, but they have high costs, side effects, challenges with adherence, and weight regain. The weight regain has been discussed, which is why, again and again, one of the take-home messages from all the speakers is these drugs should be prescribed with wraparound lifestyle only. Beyond the high cost, they have gastrointestinal side effects, muscle and bone loss, which has been mentioned, which then with weight regain will just be fat regain, leading to sarcopenic obesity. In the United States, from a very large analysis, 75% of people stop taking the drug after 1 year, 75%. And so many people will regain the weight. And so they may be worse off than when they started. And so we recently published a joint advisory from the American College of Lifestyle Medicine, the American Society for Nutrition, the Obesity Medicine Association, and the Obesity Society, which I encourage all of you to look at in the 4 journals of all of the societies at open access, in how we should really be thinking about nutrition and lifestyle for a recipe for success. And so there are really all of these issues that have to be done. We have to complete baseline screening. We have to manage GI side effects during the up ramp. We have to navigate dietary preferences and intakes, prevent nutrient deficiencies, preserve muscle and bone loss, maximize weight reduction, promote other supportive lifestyle, and be sure we're treating the patient holistically. Now, I don't know the exact language in the UK, but really interestingly, in the United States, the drugs are FDA approved for obesity treatment as an adjunct to nutrition and lifestyle, not the other way around. And I think that's very telling. These drugs are not intended to be prescribed and then have nutrition and lifestyle be supportive. These drugs are intended to be prescribed as supportive to nutrition and lifestyle. And honestly, I think it's probably not happening very often in real life in the UK, just as in the US. And so I think we're really prescribing these drugs unethically and against the standards by not providing wraparound nutrition and lifestyle. So I'm not going to go into too much detail here because of time, but this is in our paper. Starting before the drugs are even started, there really has to be a comprehensive assessment of what's the person's goals, what's their life stage, what are their social determinants of health and barriers, what are the benefits and risks, what are the complementary things they need to do for nutrition and lifestyle, come up with a shared plan, address challenges and barriers to food access, to physical activity, and so on, refer to specialists, for example, for psychological issues or other issues, so that the drugs can then be used effectively. And I think it's also really important, what I'm going to focus on now, talking about nutrition, is what should the actual nutritional prescription be? This is a trial now 20 years old, which showed that 4 diets, Atkins, Zone, Weight Watchers, and Ornish, all had relatively similar effects on weight loss. And what the chart shows is adherence was relatively poor for all of the diets. And so one of the conclusions from these short-term trials, these 1-year trials of weight loss, has been that adherence is most important, and really any diet works. And I think that's true short-term. For 6 months or 1 year, somebody could go on any diet they wanted as long as they're adherent and watch their calories. But what I want to talk about here really is for long-term success, we're learning that physiology matters more than willpower, and biology matters more than conscious choice. And so when we're talking 5 years, 10 years, which is really the time scale we have to be thinking about, we have to think about food and biology, not just this issue of short-term adherence. And this is because we're learning that long-term foods have complicated effects on our physiology that are independent of their calorie content. And so you can give people exactly the same calories and have very different effects on a range of physiologic responses, including metabolic rate, the gut microbiome, brain reward, fat synthesis, and many other factors. So we really have to think about diet quality beyond calories. Food is really biologic information. What we eat, independent of its calories, determines the rate of digestion of the food, the location of the digestion. Is it in the stomach, in the small intestine, or in the large intestine, where the microbiota can also participate? The completeness of digestion. Do we digest all the calories, or does our microbiome digest some of the calories? It dramatically affects the gut microbes. As I mentioned, these bacteria alter how much of the calories we digest, where the energy goes. Does it go to skeletal muscle? Does it go to fat cells? Does it go to protein synthesis? And our gut microbiome alters our behavior, alters our mood, our diet, our hunger, through the nutrients that they receive and the metabolites that they create. As I'll show you briefly, what we eat actually also seems to alter resting energy expenditure through probably thermogenesis in adipose tissues and skeletal muscles. So our basal resting energy expenditure can change depending on what we eat. And then, of course, what we eat alters our epigenetics in mothers and fathers, which leads to intergenerational risk. So my kind of take-home message, adding to what others have said, is that beyond focusing on nutrition and lifestyle, diet quality and the quality of the diet is really critical. And there's many papers showing this. This is just one example. There's been papers in the US and in Japan, for example, looking at ultra-processed foods, even matching for available calories, fat, sugar, salt, carb, protein, fiber, and energy density, When people are presented with ultra-processed foods, they overeat and they gain weight unconsciously. And in contrast, when they're presented with minimally processed foods, they eat less and they lose weight. And so here you see in a randomized controlled trial, people eat on average about 500 calories more on an ultra-processed diet, even without realizing it, and they gain about 1 kilogram in 2 weeks. Whereas on an unprocessed diet, they eat less and they lose weight without even realizing it. Now, why do ultra-processed foods have such powerful effects? I think one of the things that we're learning is the impact of acellular nutrition. This is where you've lost natural cell structure that nutrients should be in. You get rapid digestion in the stomach and small intestine, rapid glycemia and insulinemia, and if it's protein, proteinemia and insulinemia, loss of microbial prebiotics. The acellular ultra-processed foods have lost their prebiotics. And calories actually get digested by the host instead of the microbiome. And so if you have a food digested without intact cell structure, more calories are digested by the person than by the microbiome. And this calorie partitioning has not really been well recognized by clinicians to date. Also, as I'll talk about, what we eat actually alters thermogenesis, the generation of heat, our resting energy expenditure, and intergenerational risk through epigenetics that's passed on from mother to child. So even with the same environment, with the same diet, a child's epigenetics can make them more predisposed to weight gain and make it harder to lose weight. Now, there's been several really fascinating papers on this. This is just a couple of examples. This was a study looking at about 5,000 adults in the US and UK over time, and in some cases, the same cohort over time. And what it showed is that total energy expenditure in these adults has declined. Total energy expenditure has declined by about 220 calories per day. That's a big, big decline in energy expenditure, which makes it very, very hard to lose weight, because even if you're eating the same or even if you're eating less, you're going to be gaining weight when your energy expenditure is down 222 calories a day. But what's critical is that physical activity energy expenditure actually went up during this period. It was resting energy expenditure that's gone down. There's been many, many papers showing this, that in modern countries, in modern life, our resting energy expenditure has declined substantially, maybe by 200 or 300 calories per day, which is why we're having so much trouble with the obesity epidemic. And another analysis looking at 34 populations across 6 continents showed the same thing, that activity energy expenditure was constant across multiple populations, but in high income modern populations, resting energy expenditure was down by between 6 to 11%. So, and I think that's because of thermogenesis and other issues, the microbiome, which we can talk about. So ultimately, for the best recipe and the best prescription for our patients on GLP-1s, we really have to think about the science-based priorities for foods that will support weight loss, thermogenesis, healthy epigenetics, and healthy microbiome. We have to have protective foods that are minimally processed, that are phytonutrient rich, that are loaded with positive things that will help thermogenesis, the gut microbiome, lower insulin, reduce fat synthesis, and long-term have physiologic benefits. And so this is fruits, nuts, fish, vegetables, plant oils, including seed oils, whole grains, beans, and yogurt. Minimally processed animal foods we can eat in moderation. Cheese is actually a fermented food and is linked to low risk of diabetes and not linked to weight gain. So cheese is probably the highest on the list of these minimally processed animal foods. Unprocessed red meats is a little lower on the list. It's probably the lowest on the list because it's linked to colorectal cancer and to diabetes, not because of the fat or the saturated fat, but because of the pro-inflammatory compounds in red meat, with heme iron actually being the signature pro-inflammatory compound in red meat. It's what makes meat red. But animal foods on average can be eaten in moderation. And then really the worst foods that we have to minimize are the ultra-processed foods that are high in starch, sugar, and salt. And I'm going to say that again, starch, sugar, and salt, because for too long I've heard people talk about fat, sugar, and salt as the problem, or fatty foods as the problem. We need to be eating more fatty foods. We need to be having lots of plant oils. Cheese and milk and eggs and butter are pretty neutral. It's really starch, sugar, and salt that are the problem, not fat, sugar, and salt. And so starch is probably the single biggest problem for obesity and weight gain. Now, this roughly corresponds to minimally processed versus ultra-processed, but not perfectly. But if we avoid starch, sugar, and salt in ultra-processed foods and eat minimally processed foods, I think that's very, very important for patients on GLP-1s. And in our paper that I mentioned, we kind of go over food groups to eat more of, food groups to avoid, and also eating habits, the way you can eat to try to help patients with GLP-1s. And again, this is in our paper. I won't go into too much detail. I just want to end in my last few minutes by talking about last couple of minutes by talking about a new wave in the United States, which I hope comes to the United Kingdom, is that just telling patients that they should eat healthier and giving them guidance only goes so far, only works for some patients, and especially works for patients who have more education and more income. And so it tends to worsen health equity. And so we're really excited about food as medicine, where healthcare providers can not only give advice, but they can actually prescribe medically tailored meals, medically tailored groceries, produce prescription programs to help support patients with a range of conditions, including potentially GLP-1s. And so we have proposed, and we have some research projects in planning to test this hypothesis that maybe if you give patients with GLP-1 agonists, not just advice, but food as medicine prescriptions, $100 a month of healthy, minimally processed food, you can actually help many, many patients with long-term weight maintenance. And some patients may even be able to come off the drug successfully and stay off the drug for months or years if they want to, if they choose to do so, and not regain the weight. And some patients may need to be on GLP-1s for life, but the food as medicine will help them with better outcomes. And I just want to end with this last slide, where this isn't seen in all patients, but I have seen this and also others have seen this. This is a New York Times Magazine article. Some patients, not only they eat less, they change their preference for what they eat. This is seen, and it's very interesting. They basically lose their preference for ultra-processed foods and begin to crave healthy foods, which is how I feel every day. And so if you read these quotes, he took us straight past the Doritos without a side glance at the Oreos or Cheetos. We rushed past the Pop-Tarts and Hershey's Kisses, the Lucky Charms and Lay's. We arrived at his happy place, the produce section. I ate a lot of pineapple, cucumber, ginger. Patients on GLP-1, some of them, they can't eat candy anymore. They take things it's so sweet. They crave fruit and vegetables and carrots. And this, I love this quote, a Hostess Ho-Ho, which is a very processed cupcake, no longer seems like food, she said. It tastes plasticky, feels plasticky in my mouth. I think this is fascinating because I think it's showing us that many patients with obesity actually have GLP-1 resistance or GLP-1 deficiency, and that we're restoring their normal human taste. The normal human taste, I believe, is to eat minimally processed foods, not to eat ultra-processed foods that are high in starch, sugar, and salt. Those foods actually don't taste that good, and it's through our modern life we've altered our GLP-1 signaling. So I think that's actually one of the most interesting things about GLP-1s, that they're giving us a window into natural human physiology. And it gives me hope, because for so long we've been told that industry has hooked us on these biologic pathways for sugar and salt and starch, and we can't avoid it, and we can't resist it. I think that's not true. I think the GLP-1 drugs are showing that the natural, normal human physiology actually does not prefer unhealthy processed foods, but prefers minimally processed healthy foods. Thank you.
Fantastic. Thank you, Darish. That was a really great talk. And all speakers perfectly kept to time, so lots of time for questions. So I've got the list of the questions that have been upvoted. So to begin with, are there any specific vitamins or minerals that should be prioritized for GLP-1 users? Dwayne, shall we start with you?
Well, we know that the ones that are generally low in the diet in the UK, we've got iron, we've got vitamin D, which is low in this population. B12 may be at risk because they may have type 2 diabetes with metformin. So if we're doing our metabolic profile beforehand, we'll be picking those up. Whether I'd advocate the same sort of style of fortification that you see in bariatric surgery, I don't think we have the evidence yet. There are some parallels with bariatric surgery in terms of nutritional effects, but they're not completely the same. We don't know. So I'd probably do it based on a risk-based approach, that you know which ones to look for, then you should look and manage them. And I agree with both the other speakers. It's about getting a nutrient-dense, high-quality diet, knowing that they're going to reduce their consumption is the key thing first, then looking to screen for deficiencies and manage them as they see. And it's ideally should be looking for that before you start them on the treatments, because they're likely to be deficient. And as the Bush paper says, there are a large number who are deficient before they started on the medication.
Brilliant, thank you. Dariush, the next one for you, if you wouldn't mind. Do you know of any specific dietary recommendations proposed for GLP-1 users? So, for example, X grams of protein per day?
Yeah, so we cover this in our report. I agree with the statement that was made is people should have adequate protein, but most people in the UK and the US are already having adequate protein. What they really need to do is get on a strength training program, because just eating protein by itself won't build muscle and won't even really preserve muscle that well. So you really need to be on a strength training program. So I think more important than protein quantity, although it's helpful, is a strength training program. Beyond that, as I mentioned, I think the most important diet for long-term success is minimally processed, phytonutrient-rich, plant-forward, minimizing ultra-processed foods.
Fantastic, thank you. Sahar, we've got one for you here. Is there any guidance about whether patients should titrate down from their medications when they're coming to the end of usage?
So what we do know is the licensing of the drug, which is weight loss and weight maintenance. So what I do in my practice is once someone has reached their target weight, we look at what is a suitable maintenance dose. Some patients are not ready to titrate down and stop straight away as soon as they've reached their target weight. And every patient will be different. Some patients will, the month that they reach their target weight, they want to titrate down step by step. And then some will want to stay on that same dose as maintenance, and then for a few months, and then slowly titrate down. So there's no official guidance out there when it comes to maintenance. I'm sure guidance will come out, the further studies that are being done. But I think it's that individual consultation with that patient, how they are feeling, because you don't want to rush somebody to start titrating down when they haven't absolutely nailed the diet and the exercise and the mindset. Because if you start to titrate them down and their diet's still not right, they're not moving their bodies enough, they will then have weight gain, which then means, do they need another higher dose? And then you're kind of going up and down the titration schedule. So I think it's really about peeling back the layers with the patient, and the patient really being honest with you and how they're progressing with their treatment and what changes they've made.
Great, thank you very much. This one I think will go round all of you to get your views, but do you think the lifestyle support should begin prior to commencing the medication? So Dwayne, we'll start with you.
My view is we should be flagging it to them that they will need to make lifestyle change. I think I said in my talk, quite often would have an adversarial approach, or can feel adversarial, with a lot of people who live with high body weight to start off with. So we say, look, we can start with the medication. These are the changes that are needed. And then you introduce and build and build and build. And then you look to a point where you're looking to off-ramp them off the medication or titrate down the medication. So you're looking, so you've got the behavioural cues, the lifestyle cues, and the diet changes well embedded then. But I think it's important to say it's coming, but let's get some success first. If you try and put the diet in first, you may switch them off and make it a harder battle later on. So you need to work with them through that. We don't have evidence. That's more of a gut feeling, to be honest.
Thank you. Sahar, what about you? I also think I've just accidentally muted you.
Okay. So I have the conversation around diet and lifestyle changes from the very beginning in terms of an expectation for patients. Like, I will say to them, look, the medication is one tool, but it has to be done with the lifestyle and diet. I've written an ebook guide for all my patients, and it does cover all the lifestyle and the diet stuff, like sleep, stress, diet, exercise, nutrition, gut health is a big one. So they get that from the very beginning. But I think practically, not every patient is going to make changes from day one. But I think it's about the importance of that follow-up, that constant check and that touch point that they're getting with me, that then we can reinforce the points and really get them to start making those changes. They may not happen straight away, but I think it's important that patients are set up and their expectations are set up as well from the very beginning, so that then, because it is very hard for patients to then be on this medication for, say, 12 months and not really have made any diet or lifestyle change, and then for me to say, right, you've reached your target weight, it's now time to start titrating down, and they have that anxiety around, hold on a minute, I've not actually changed my lifestyle, and now I'm having to let go of the medication. So I think it's just that expectation, setting patients up so that they know what to expect.
Brilliant, thank you. And Dariush, any final thoughts from you?
Yeah. So I a two-part answer. I agree with Dwayne that we shouldn't be rationing the drugs and saying, look, if you don't do your lifestyle, you're not going to get the drug. If a patient is clinically indicated and ready to get the drug, they should. But all patients with a BMI over 30 from class 1A recommendations from all societies should already be getting lifestyle recommendations. That's the problem. The fundamental problem is the health system's not doing that to begin with. And so yes, they all should have been gotten it already, and it should be a fundamental part of healthcare, and it's not. That's the biggest problem, that the top cause of poor health, nutrition, is missing from the healthcare system. Everyone on this call cares about nutrition. If we care about health, cares about health, everyone on this call cares about health. If we care about health, nutrition has to be at the top of the list, not top 3, not top 5, not top 10. That the number one thing the healthcare system needs to focus on is better nutrition and lifestyle. So yes, they should all be receiving it, but not as a ration or a check of whether they receive the drug.
Fantastic, thank you. I'm conscious of time, so just before we close, I wanted to say a huge thank you to everyone that's been a speaker today, and also to all of you that have attended. Apologies if we haven't had time to answer your questions. We will be sharing today's recording following the webinar. It will be on our website along with our joint position statement that Dwayne kindly mentioned, that was with the BDA regarding weight loss drugs in people living with obesity and type 2 diabetes. A huge thank you again, and hopefully we will see you at another webinar soon.